are you guys? I'm Stacy McGee. I'm the Wellness Specialist here at BI.
I'm Sean Lawrence, the Health Fitness Manager at the AOB Fitness Center.
In 2014, the wellness and fitness teams will focus on musculoskeletal issues and topics. And we created a year-long program called Back in Action. We're pretty excited about it, and it's designed to educate you about the importance of back health. As part of this program, we focus on the anatomy of the back strength, flexibility, and common injuries and pain. Our first video, which we'll be doing today, is going to be focused on the anatomy and function of the back. And with us, we have Dr. Kyle Worrell, Dr. David Bombach, and Gail Fennell. I'm going to give a brief introduction for you guys and what you guys do. Okay? Dr. Kyle Worrell has been in private practice since 2000, specializing in non-operative and post-operative cervical and lumbar spine chiropractic and spinal rehabilitation. He received his doctorate of chiropractic from the National College of Chiropractic. Dr. Worrell is a board-certified doctor of chiropractic and leading practitioner with more than 13 years' experience caring for lower back, neck, muscular, and nerve injuries. Throughout his career, Dr. Kyle's passion for sports medicine and chiropractic has driven him to stay at the forefront of his industry. Through research in the area of rehabilitative therapy, use of Cox flexion decompression technique, and certifications in manual therapy and golf mechanics, Dr. Kyle is also a certified specialist in strength conditioning and a USA Triathlon certified coach. Welcome, Dr. Kyle.
Thank you.
Dr. David Bombach is a spine surgeon and recognized leader in the field of complex spinal surgery. Dr. Bombach earned his medical degree at Columbia College of Physicians and Surgeons at Columbia University. He then completed his internship and residency in orthopedic surgery at Yale New Haven Hospital, and ultimately served as chief resident there as well. Dr. Bombach then completed a spine and scoliosis fellowship at the world-renowned Hospital for Special Surgery in New York, New York, studying all aspects of the spine, including both pediatric and adult. He practices in Danbury, Connecticut, and has a state and nationally recognized Connecticut back specialist. He devotes his entire practice to spine care, both surgical and non-surgical. Welcome, Dr. Bombach.
Thanks for having me.
And last but certainly not least, we have Gail Fennell, physical therapist. Gail has been in private practice in Richfield since 1990 with Carlson Physical Therapy as clinic manager, and in 2005 she partnered with them to open Carlson Therapy and Spine Rehab in Danbury. Gail received her bachelor's degree from SUNY Downstate Medical Center in 1987. Since then, Gail has specialized in the care of the spine with extensive continuing education and training in manual therapy, muscle energy technique, myofascial release, advanced strain counter-strain, cranial sacral therapy, visceral immobilization, neural tissue tension release, Mulligan mobilization, and lumbar segmental spinal stabilization exercise. She's an expert in the treatment of scoliosis and is the only certified Scroth scoliosis physical therapist in practice in the state of Connecticut. Welcome, Gail. Thank you. You're welcome.
Thank you guys for all coming, being with us today. We're going to just jump right into our questions. Feel free to jump in and answer. The most important thing I think that we all want to know is what is the back and its main function in the human body. So feel free to just kind of elaborate on its main function.
You want to take that one? Or I'll start with that one. All right, so basically we divide the skeleton into two different types. We have what we call the axial skeleton and the appendicular skeleton. The axial skeleton is basically your backbone, the central part of your spine. The appendicular, which comes from the Latin root, the appendage, refers to the extremities. So you have the appendicular skeleton, meaning your arms, your legs, and then further out, the more distal extremities. So when we refer to the back itself, we're talking more about the axial skeleton. And the back itself can be divided into different regions when we talk about the actual vertebral column or the spine. And Kyle will get more into this when he starts talking more about some of the stuff that the chiropractic treatments address. But basically we have our skull, which is called the occiput, and then we have basic four regions in the spine. We have the cervical spine, which sometimes we just call the C-spine because it's a little bit easier, the thoracic spine, and the lumbar spine, and then the last region is the sacrum. There is a vestigial or remnant structure known as the coccyx, which is the layman's term would be the tailbone, which really has no function other than to just cause pain. I saw someone in my office about 2 hours ago that came with tailbone pain. It's very much like your appendix. You don't want it, but you're stuck having it, so you got to deal with complications related to it. So those are the four different sections of the spine. There were multiple muscular attachments, ligamentous attachments, tendon attachments. that help provide structure and function and mobility to allow this part of the body to do what it does. You guys can elaborate more.
Yeah, essentially David said that too. Is when it comes down to it, the purpose of the back is for form and function. David, talked about the structure of it, and the function of it is that it supports our body. It supports the muscular and bony structure of our body, as well as the function part of it, which is it houses one of the most important nervous system parts of our body, which is the central nervous system, where the brain ends, the spinal column, and the spinal cord begins. And that function, supports the nerves that majority of the nerves all begin in the spinal cord.
So I'll talk a little bit about motion, because that's what I'm about. So the spinal cord allows us to be mobile and provide and perform a task. Mm-hmm. So walking bipedal is one of the reasons why we have the curves that we have in our spine, and being able to get from point A to point B, and so it allows us to do all of that. So looking at it from a movement perspective.
So we're born as infants and in utero with this sort of C-shaped spine, mm-hmm. right? As we stand up on two legs, what Gail's referring to as bipedal gait or posture, and there's not a lot of bipedal organisms on this earth, our spine takes that shape, and the shape that it takes, as you'll see, is no longer that C-shaped curvature. You may see that in older patients with some spinal deformities, but in general, the spine takes this S-shaped curvature. Mm-hmm. When you're looking at it in the side plane. We call that the sagittal plane, mm-hmm. which is just looking at the spine from the side. So basically what you have is you have that cervical spine we spoke about, which has that normal lordosis or reversed C curvature. Then you have the thoracic spine, which takes a little bit of a reverse C curvature in the opposite direction, what we call kyphosis, and then the lumbar spine comes back to that C again. So basically you have that S-shaped curve giving you lordosis, kyphosis, and lordosis. Now that's normal to have that. You can have excessive amounts of lordosis or excessive amounts of kyphosis, mm-hmm. And then that can lead to a host of different problems which can be treated operatively or non-operatively. But the actual anatomy of the spine is dependent on a lot of different things, and it's basically the way we develop shapes. Kyle was talking about form and function, shapes the way the spine actually develops.
So the spine pretty much keeps us from being a jellyfish. Gives us that form and function. Sounds like our...
Keeps us upright.
Yeah.
We are bipedal, animals, and like a lot of other animals on Earth, they're walking around on four. We're walking around on two, mm-hmm. and it's the sole structure that keeps us up there.
Okay. And there's so many terms that they use to describe the back, like core, and upper back and lower back. Can you give us a little? I know you talked about cervical, thoracic, and lumbar, but where would the lower back start and where would the lower back end?
Well, David already explained the what the spine is and
right.
the different sections
right.
of the spine. To break it down a little further, there's terminology that people throw around all
right,
the time.
Right.
It starts with the bones of the
right.
back,
mm-hmm.
the vertebrae. They are the movable segments, the small bones in each level of what David referred to as the cervical, thoracic, lumbar, and sacral regions of the spine. Those are the vertebrae. Mm-hmm. 24 movable segments, actually, bones there that are supported in between by what are called the discs. I think that was another term that we wanted to clarify.
Right.
The discs are basically the jelly donuts in between each of those. They are the supporting soft structure of the spine.
Okay.
I think you just asked also about a term that's thrown around mostly these days called the core.
Yes.
Basically, what core refers to, it's a sort of a nuance, these days to describe a certain area, especially when it comes to the function and what operable parts are there. Mm-hmm. It basically is the area between the ribs and the pelvis,
okay.
The front side and the back side between the ribs and the pelvis.
Awesome, thank you.
I would also incorporate a little bit of the shoulders into that as well too. So if you're working on strengthening and looking at it from also supporting the neck, mm-hmm. which from a biomechanics and functional standpoint, that becomes very important as we move forward in our electronic age, and we tend to be more in a forward posture and looking down. And so upper back strength is mm-hmm. critical for maintaining proper posture and having good health, not only for the back, but then also extending up to the neck. So there's a crossover there.
Wonderful, thank you.
So I think we talked a lot about the bones and what makes up the back, but I'm a fitness guy. I do a lot with movement, a lot of exercise, and people come in and want to know about the muscles in the back, and was hoping you can explain a little bit about that. What muscles are connected to the spine? What are we doing? How the muscles move, and what daily functions are we elaborating with the muscles in?
Well, for purposes of keeping this, short of a 3-hour lecture on anatomy, let's sort of break down some terms that are thrown around in the public too, because people talk about muscles and they talk about certain areas of the body. Sometimes there's confusion and sometimes there's not. The bigger muscle groups or the bigger muscles that are thrown around oftentimes are the lats, the traps, the rhomboids, the neck muscles, the glutes, and then outside of the spine, the hamstrings and hip flexors. To utilize the spine and just go over certain places on the spine as far as where those muscles run. The lats are the muscle that basically run from the top of the pelvis, off the pelvic crest, out towards the arm. They're a very large, flat muscle that runs almost in a triangular shape that direction towards the humerus. The traps that people often refer to, the word indicates, it's a trapezius, and they run basically from the base of the skull down through the middle, lower end of the top of the spine, and again out towards the shoulder blades in a trapezius type fashion. Muscles that are also commonly talked about are the rhomboids, which run basically off the spine towards the shoulder blade. Deeper to that, and probably the more important muscles of the actual spine that no one really pays enough attention to, are the spinal muscles. The spinal muscles that run basically from the top of the pelvis or down and through off the sacrum, and the bony structures that come off of the vertebrae that run certain segments, certain levels, all the way up from the base of the spine into the base of the skull.
So you mentioned that those actual muscles aren't targeted enough. Can you tell us why we should target those muscles?
Yeah, and I'll probably actually lean over towards the function person a little bit more too to expand. Okay. But those muscles are sometimes ignored. They're deeper muscles. They're not what people see, so they're not actually in front of the mirror, or they're not actually muscles that people can tangibly work on sometimes, or know that they're working on them or not. They're often referred to in those core muscles as well, the deeper muscles called the erector spinae and the multifidi muscles. I'll let Gail take over now.
Okay. So starting from the core out, if you really want to use the term core, the multifidus muscle is extremely important for what we call the circle of integrity. The transverse abdominis is another muscle. It's the deepest of the 4 abdominal muscles. And together those two can really help to stabilize particularly the lumbar region of the spine. So if we're working, and now it's more in vogue in gyms to see functional exercises, and which is much more appropriate to performing daily tasks. So doing those functional exercises, you need to start at the deeper muscles and be able to learn how to engage those deeper muscles so that then you can carry forth and be able to strengthen what we call the global muscles, or the other muscles that are on the outside, the obliques, the latissimus. And so if you can start initiating the motions from the actual core, you can better stabilize and have a power center to move from, and then be able to lift a load, move a load, and be able to protect that area of your spine in the alignment it's supposed to be in, which is a neutral position of the spine.
Yeah, some of these muscles are tiny little muscles, and when we operate, we can actually identify there are little individual muscles called rotator muscles, the multifidi that we spoke about. And then there are multiple layers of muscles throughout the spine, the semispinalis, in different layers that are not of any real importance in terms of their name. And the reason why we don't focus on their names is because these muscles can't be isolated individually. You can't go to the gym and work out a multifidus, right? Like you could isolate a bicep or isolate a tricep. So that's the whole reason why core strengthening is sort of a buzzword, because there's no way to go and just say, I'm going to work only my erector spinae muscle. You're going to engage your abdominal muscles. You're going to engage a lot of these other, your quadratus lumborum. You're going to engage a lot of these muscles that are help supporting the structure of the spine. So they kind of get lumped in, and we sort of just kind of refer to these muscles as sort of paraspinal muscles, which are just, all that means is just muscles that are running along the midline, off the midline of the spine, just parallel to the spine. That's what that para prefix implies. So you can have cervical paraspinal muscles, thoracic paraspinal muscles, lumbar paraspinal muscles, and they just kind of get lumped in to multiple muscle groups that have slightly different functions, but basically all help support that individual motion segment.
Great, thank you. Thank you. So can each of you, I know you guys come with different expertise and different backgrounds, and chiropractor, physical therapist, orthopedic surgeon. Can you explain to us your specialties and how they relate to back pain and common reasons why a patient would come to you. Start with Dr. Worrell.
Well, as a chiropractor, sometimes I end up being the portal of care, or the beginning when someone actually has an instance of back or neck pain. As a chiropractor, people often seek me out because they have that acute instance of back pain where they picked something up, or they lifted a child, or they actually hurt themselves in the gym, where they're in severe pain and they want an answer.
Right.
Oftentimes people are walking into the office, huddled over, and that's where it starts. As a chiropractor, I find myself as an important part of the first part of the paradigm of back pain. Folks will come in and they're looking for a solution. It's often pain. It's often related to function. How can I help them get back to work, get them back to fitness, or back to life? So taking a patient in, it's the first instance of pain and what I'm going to do for it then afterwards. I look to actually address that person's concern by getting them out of pain, and also working them through that paradigm towards greater form and function too. Starting them off on a plan of exercise, or starting them off on a plan of actually regular postural exercise at a minimum. So take it further than that. Sometimes I'm dealing with patients on a regular basis towards wellness, towards increasing their awareness of what they're doing and not doing in their lifestyle, increasing their awareness of actually their posture and their overall spinal health.
Excellent. Gail?
The majority of the patients that I see will come to me similar to Dr. Worrell because they're not able to do something, whether it's pain that's limiting their ability to do something, or a lack of mobility that's preventing them from doing a specific task, or giving them pain with a specific task. For example, for your sales force, getting in and out of a car, for someone sitting at a desk all day, getting up from the chair. So something along those lines will bring someone in. So it can be from a very acute situation, or someone who's having a complaint of something that's just nagging and not going away. So look at them from a movement perspective, an analysis of what's sort of happening with where they're restricted, what I can do to help decrease the pain, the behaviors that are feeding into the pain pattern, to get them to stop those particular behaviors, teach them other ways to change that so that they can help to get out of pain more quickly, get them moving more, and then work on their stability and strength, teach them proper body mechanics on how to then prevent that from happening again. And what are the signs and symptoms to pay attention to in terms of warning signs, when to get back to doing some corrective exercises, or when to come back and seek help again. But get them towards independence of being able to exercise, know their postural changes, know their body mechanics, and be able to carry on with their life and do those tasks.
Thank you.
Now, do you see people, or could be 50-50, do you see people more with acute back pain or chronic back pain, or kind of goes?
In my practice, it varies from everything from post-operative patients to someone who just, as Dr. Rowe was saying, lifted a child over the weekend and injured their back, and from that, from any age up to 87, or from, even adolescents who are injured on the field. So it really varies. The commonality really for me is looking at their movement and where they're getting their pain with their movement, and being able then to address that. So whether it's they can't move because they just had surgery, or they can't move because they just came off the sports field, or they can't move because they're sitting at a desk all day. So it's really has to do with more their function.
In my instance too, it varies. I often say that patients usually come in, with a problem, in pain, sometimes huddled over. But as my practice has grown too, I think the awareness of spinal health and exercise and everything else, patients are now starting to come in more on a little bit more of a wellness aspect too, where they're looking to do for themselves before they get to a certain place.
It's almost
usually
like prehab.
Yeah, it's prehab, especially when it comes to surgery or actually physical therapy. There's a part that I think, as we educate for the folks on spinal health, people are becoming more aware about what to do for their back, because they don't want to be like their neighbor that is huddled over in pain one day.
Great, thanks. Dr. Bombeck?
Yeah, I'll see a real mixed picture as to what can come into the office. And truthfully, if somebody in acute pain, other than the power of the pen, where I can write prescriptions for different medications, which we'll get into later, Gail and Kyle are more adept at treating those patients. They have the skill set to do adjustments and to do manual manipulations to sort of help relieve areas of muscle spasm, or of inflammation, or of joints that may be locked up. And that's not my skill set. my skill set is to sort of evaluate these patients, get a sense of what I think they would benefit from. Do I think they would benefit from just simply rest, ice, anti-inflammatories, maybe a muscle relaxant, maybe a steroid, a lot of different ways to get inflammation down acutely, and maybe that's enough. Do I think they need a little lesson in sort of healthy back and kind of teaching people proper body mechanics and healthy lifestyle, and that we can implement. But then I have to decide, would they benefit from more than that? Do they need some more conservative care, either chiropractic, physical therapy, perhaps acupuncture, perhaps some sort of injection may be the way to go. And then a very small subset of patients, probably in that 10 to 15% range of all the patients I see, we're not able to control conservatively. And those are the patients that ultimately may need surgery. So a lot of patients are reluctant to come see me because they think when they're going to see the spine surgeon, it means that they're going to get operated on. It's actually the opposite. Usually 80 to 90% of patients we can successfully treat non-operatively. But there are a small subset of patients that we just can't get better without surgery, or even if they're not in pain, they have something that's very concerning, whether it's weakness, whether there's a tumor, whether there's something else that just has to be addressed, that has to be operated on. So people are reluctant. I had some patients come and say, I didn't want to come to see the spine surgeon, but I'm here anyway. And then they kind of leave with sort of a breath of fresh air when I talk about, okay, I'm sending you to a physical therapist, or I'm sending you to a chiropractor. Right? So I'll see a mixed picture too. I probably see a little bit more chronic back pain than maybe these two see, because they're dealing with a lot more of acute on chronic situations, because people with chronic back pain sort of tend to live with it. And there may be a structural problem while they're having chronic back pain. But I'll see a real mixed picture from acute to chronic. It's probably a 50-50 mix.
So you kind of view it as a last defense kind of thing, but
Yeah.
you're really not.
Well, what we do is we set up a treatment algorithm for patients, and I take them through this continuum of care, assuming there's nothing that has to be done operatively. In other words, nothing is forcing us to operate. There's no surgical urgency or emergency. And we start, the most conservative in my mind is what we call in the medical field benign neglect, right? It means you leave it alone, you forget it ever happened, and you just deal with it, right? You don't treat it, you just leave it alone. Moving on from benign neglect, you start with some sort of medication, right? Tylenol, an anti-inflammatory, and we can talk about that. And then you start talking about some sort of conservative treatment plan that's non-interventional, nothing invasive. And that's where I like to look at that as some sort of manipulation, whether it's an adjustment, whether it's therapy, but it can be chiropractic, physical therapy, physiatry, osteopathic medicine, prolotherapy, acupuncture, this whole realm of conservative care. Then you get to the next step, where I would consider sort of the intermediate step between conservative care and surgery, and that's some sort of injection type of procedure. You may hear patients going for epidural injections, sacroiliac injections, facet joint injections, different areas of the spine that can be inflamed. And then the ultimate last resort is surgery. So we try to walk them down that pathway and have them sort of check the boxes, and if you fail all those boxes, then we do have an answer for you most times. And then that's the last resort. So we're not looking to operate until we've proven every other modality up to that point has failed.
Excellent, thank you.
Sure.
You guys did an excellent job with the anatomy. We are so thankful you took the time out of your day to come and share about our Back in Action program. Thank you once again. We appreciate it.
Thank you very much.
Thank you very much, Travis.